Again, this does not include the headrest E0955, just like we had by power tilt. When a patient goes into a posterior position, they need to catch their head. When the patient's sitting straight up, their head can sit straight up. Somebody with good head control, they're fine. As soon as you start going back, you want to relax, you need something to grab your head. So you're gonna qualify and require a headrest. You cannot give out a power recline or a power tilt seating system without having a headrest on that chair. You'll probably have the code again, E1028. The hardware to mount the headrest is also not included, but it's important to note, if you're giving somebody tilt or recline, make sure they have a headrest on that chair. Okay, Medicare coverage criteria is the same exact that we had for the tilt. Basically, if they're covered in 1, 2, and 3, meaning the patient meets all coverage criteria for a power wheelchair, they're unable to get around their home, they with ADL care, they're unable to use a cane, walker, manual wheelchair, or scooter, they're willing and able to operate a motorized wheelchair, and now we also have that your patient meets all coverage for a power wheelchair. There is a specialty evaluation performed by the PT because we're doing something custom now. Power recline requires to have a letter of medical necessity in addition to the doctor's face-to-face chart note. And number 3, we have to have the ATP involved in the recommendation from the provider. Power elevating seat system, HCPCS code E2300. Now, this code is it includes the motor-related electronics, programmability, a switch controller, any hardware that is needed to attach the seating system. It must provide a seat elevation of at least 6 inches. So now, there are different types of power elevating seats. One is what they call a single post system, where the post kind of telescopes in and out of itself and the whole seat goes up and down. When the seat elevates to the top of 6 inches, many patients have found that they feel less stable because what's happening is their entire seat is on a little pole right underneath them, and then at the bottom of the pole is kind of on the wheelchair base. If you can visualize that, there's a motorized wheelchair base and just one pole coming out the middle of the base, right beneath the middle of the seat, pushing the seat up 6 or 7 inches. The other system that they have now, this is more of a newer system, it's called the scissor system, where you have 4 points that go up like this and down. So there's like these brackets that are underneath the seat, and when the chair elevates, you're always going to have 4 points of contact that go up that are touching the seat and touching the base. It makes it much more stable. It also allows for the seat to go much higher because you're not relying on a post that's going to go somewhere into the ground. So right now you can go full 12 inches if you're using a scissor system. What's important to note is power elevating seat, Medicare coverage criteria. There is no Medicare coverage criteria. Medicare does not pay for this item. A power seat elevating system are non-covered Medicare because it is a non-primarily medical in nature. Many benefits for a patient that would want a power elevating seat. However, it's just, even though there's a code there, Medicare has said we do not provide this equipment. We provide equipment for mobility, safe mobility, functional mobility. The power elevating seat does not fall into that category of why we're providing with your MRADLs, even though you'll have many benefits that a patient can do with power elevating seat. They can reach different cabinet surfaces. I had a patient who wanted to be able to cook. She's like, on one level, I can't sit in the pot, on top of the pot. She uses her elevating seat. She goes up. She's what she's doing. She goes back down. Many benefits. People are more and more independent. They want to get things out of different shelves in the fridge. They go into, I had a patient now who works in a hospital. He's a receptionist. And he said, I can't have my job if I'm only one height. I need to have that elevating seat. So he had to pay for it out of pocket. We are allowed to provide it. We have to write down that we're providing it, but it's not a covered item. The patient will have to pay out of pocket for these features. So as much as there are available many accessories that a patient might want that is either not covered by the insurance, or even if it's a covered item but they don't qualify for it, if a patient wants power tilt on their seat and they could weight shift, they don't have a catheter, and they don't have any tone or spasms that's going to help if they're in tilt, the patient wants it, they're allowed to pay for it, but we have to write that they want it, they don't qualify for it, and they're allowed to pay for it. Now we have power tilt and recline seating system, the combination, and that's coded E1007. So the ability to tilt to greater than or equal to 45 degrees. You have the same full tilt, you have the same full recline, it has the same 250-pound weight capacity, it includes any frame when it's basically whatever you have for tilt, whatever you have recline, together. That's what tilt recline is. So it'll have the same items, the armrest will be included, you have the same electronics, your tie downs, it's all the same idea. And now, in regard to criteria, coverage criteria, we have the same thing. Again, this does not include a headrest. Your patient's tilting and reclining, they definitely need a headrest. They definitely need a bracket for that headrest as well. Power tilt and recline seating system, HCPCS code E1007. The coverage criteria is the same for tilt, same for recline. We want to say 1, 2, and 3 are met. They need a power wheelchair. They need it for MRADLs. They can't use a cane, walker, manual wheelchair, or scooter. They, because they're getting a custom seating system, they therefore are considered complex rehab and required to have a PT or an OT, write a letter of medical necessity in addition to the doctor's face-to-face. They need to have an ATP involved in the assessment, and then they need to have the inability to perform an upper body weight shift, catheter changes, or tone. Now, ideally, if you're giving a patient tilt and recline, ideally, if the patient has increased tone and they're unable to weight shift, right, one for one, one for the other. Whichever one's affected, they can use the tilt for pressure relieving, and you want to put recline on for managed tone. But if you have a patient who doesn't have tone, all they need to do is weight shifting, and you're giving them tilt recline for weight shifting because it's the optimal redistribution of weight, like we discussed earlier. A patient does tilt recline combination if they can do as little as 15 degrees of power tilt, and they go to 120 degrees of power recline. That's what they call the optimal redistribution of weight. You can recommend that, and you can get funding for that. You just want to make sure you're noting that in your justification. You're writing the patient requires power tilt and recline combination for optimal redistribution of weight, and increase our seating tolerance as well, because what happens is they really get to move around a lot more using the combination of tilt and recline because they are redistributing their weight, they're changing their position and their gravity, so they really get much more comfortable, and they really could increase their seating tolerance. But again, if you're recommending both power tilt and power recline for the same reason, both for pressure relieving activities, what you want to do is you want to mention that the reason why you're doing this is because the combination is what's necessary for the optimal redistribution of weight. You just want to mention it and not ignore like tilt recline. You want to address the fact that you're putting a tilt recline there for the same purpose of weight shifting. Covers basically our power tilt, our power recline, our power tilt and recline, and our power elevating seat. However, there are sometimes a bariatric power positioning system can be coded K0108. Now, K0108 is a miscellaneous code. What that means is that Medicare says this is definitely a medical equipment item. However, it's not specific to a code. So sometimes you'll have custom positioning systems that'll be you may have some features you'll have like with custom seating where you did a custom mold and there's no real feature or specific code. It doesn't say this is a headrest, this is a armrest. Some things are just not specific and don't fall under that code for various reasons. You'll get a list of K0108s, and when we submit for auth, we need to put a narrative on the next each one. So K0108 just in general means it's a medical equipment, but it's not code specific, and it's going to work off the MSRP when we go for funding. So you may have a bariatric power positioning system that is only coded K0108. It didn't fall into the E1007 or E1002 system when it went to Medicare, so it just got a miscellaneous code. But let's just discuss some other clinical benefits of power seating system not covered under the Medicare policy. What that means is when you're recommending equipment, you want to first focus on why is the funding source going to pay for it. Do we meet that? Great. Let's focus on why the funding source meets it. But again, with your patient, you want to focus on what the patient needs. And we're writing a letter here to Medicare or wherever the funding source is about this patient's condition. So we want to focus on all clinical benefits they'll get from the tilt, all clinical benefits they'll get from recline. First, focus on their funding source reasons. First, say they need it for tilt, they need it for pressure, either for the catheter or for tone, but there are other reasons as well that you may be funding it. And what happens is many times you may see it the other way around. A therapist will call you and say, my patient needs it for this reason. And we're like, yeah, that's not why it's covered. So let's try to see if we can get that. But do they meet the reasons why the insurance is going to cover it? Let's focus on why the insurance covers it, and then we'll focus on the reasons why you want to have other benefits for the patient. It definitely helps with your letter of justification. Tilt clinical benefits can reduce caregiver hours required to promote independence. Positioning can facilitate swallowing and digestive function. can allow proper positioning for a track here, can improve client's line of sight. So sometimes you have a patient who's extremely kyphotic or they'll lent over. If you get them on a posterior system, they'll get better posture control also. We should put that down. They'll get much better posture control if you're sitting a bit of a posterior, letting gravity work more for you than working against you. But these aren't reasons why the insurance provides this equipment. So Medicare doesn't cover it to reduce caregiver hours or for better digestive system. Recline clinical benefits that are other benefits of recline but not included in why we're going to have why the insurance would cover it is it'll increase seating tolerance for recline with kyphosis, a trunk cast or brace, can allow proper positioning for a trach, can improve client's line of sight. Again, if a patient's kyphotic over and they just pull them back, they're going to start seeing forward. Provide passive range of motion of hips, knees during a recline cycle. Like we explained before, the recline changes the patient's hip to back goal, and while doing that, it's going to open up their range of motion, their hips, keep them loose. A lot of patients have like an increased tone where they get very tight. Reduce caregiver hours required to promote independence, can enhance the respiratory process by lengthening the trunk. Respiratory is a big reason why you'll get requests for I need a reclining back wheelchair for my patient due to respiratory issues. Respiratory, for some reason, Medicare does not cover reclining system, whether manual or power for respiratory, but it definitely is a benefit to have recline on the chair if there are respiratory concerns. Thank you very much for watching. This concludes power positioning. You should now know power tilt, power recline, power tilt and recline, power elevating seat, what the criteria is, why the patient would need it, how do we get it funded. Thanks.